Rahman Rahim. So we discussed type 1, type 2, type 3 and type 4. Let him come. We discussed the definition of hypersensitivity, that what is hypersensitivity, and we said that it is the exaggerated response, hyperactive exaggerated response of the immune system to the daily normal life allergic situation, allergens. And here the most important thing is that actually the response, exaggerated response, is on re-exposure. So that is it is an immunologic reaction. So hyper exaggerated, overreactive immunologic response to the allergen on the re-exposure. Now, different types of the situations are there, and commonly the pre-sensitized host is required. We have technically 4 types. What are the 4 types? Type 1, type 2 and type 3 and type 4. So we have some excellent student here.
No.
He said he is excellent student, he said no. So we say that, okay, what is type 1? Come on, who will tell us type 1? Yes, sit down, ma fi istiraha. Type 1. IgE, okay. IgE. Badhen? Type 1 hypersensitivity. Your friend? IG? But IgE is okay, huh? E or D? E for elephant. Okay. Yes. Type 1 hypersensitivity reaction. Yes, Ghali. Any idea?
I didn't think the last lecture.
Okay. IgE. Type 1 hypersensitivity reaction. Yes.
Immediate reaction.
Immediate reaction. Immediate hypersensitivity reaction.
Delayed reaction.
We'll use the delayed reaction. That is immediate hypersensitivity reaction. Yes. Let give them. Ghaznavi is there. Maybe yes. Type 1 hypersensitivity. Huh? He is smiling, and his smile is $1 million real. He is not giving answer, but anyway. Yes. What is your idea?
Type 1 is imperative.
Yes. Yeah. Huh? Any idea about type 1 hypersensitivity? Yes.
It's where the IgE lets the basophil degranulate and bring out all the histamine and leukotrienes and prostaglandins. And it has 3 phases. It's the immediate type. It's IgE mediated.
Very good. It's IgE mediated. So immediate type of the hypersensitivity reaction on the re-exposure. Antigen is coming from?
Outside.
From the outside, attaches to the antibody. Antibodies attaches to the mast cell, pre-sensitized mast cell. Then this antigen which is coming from the outside attached to it, mast cell degranulate. 3 mechanisms are there: immediate degranulation, prostaglandin synthesis, and what is the third one?
DNA.
From the DNA synthesis of the late phase reaction. DNA synthesis of the late phase reaction. So this is type 1 hypersensitivity reaction. What about type 2 hypersensitivity reaction? Type 2 hypersensitivity reaction.
It's about the antibody.
Yes, very good. About the antibody. Which antibody? Huh?
The complement system.
Very good. Very good. Thank you.
Killer cells.
Very good. Very good. Thal. Come here. Wallahi Mumtaz. Come here. Sit down here. Very good. Excellent. Antibody mediated. Tamam. NK cell is involved here. What else? 3 mechanisms are there. 3 mechanisms. We discussed 3 mechanisms. Killing by phagocytosis, two mechanisms are there.
One is dependent, one is independent. One is without inflammation, one is with inflammation.
So without inflammation by phagocytosis, two mechanisms are there. Then inflammation, and third is by the NK cells. Third is by the natural killer cells. This is type 2 hypersensitivity reaction. Any example of the type 2 hypersensitivity reaction? Yes. His Excellency Mali Mudir the Sheikh. Come on. What is your name? Huh? Yes, His Excellency. Come on. Any example of the type 2 hypersensitivity reaction? Anyone? No? No, not you. I know you. Yes?
Blood transfusion.
Blood transfusion. ABO incompatibility. Yes. Huh? Pernicious anemia. Very good. Excellent. Yes. Very good. Excellent. Huh?
Hemoglobin urea.
Hemoglobin urea. Very good. Excellent. Pernicious anemia. Any idea about the pernicious anemia? Yes. The man who just arrived. Huh? Yes. Any idea of the pernicious anemia? Come on. Come on, give me the answer. He will give you some fulus. Come on. Both of you, they will give you 200 real. It's a good chance to win 400 real. Come on. Yes. Any idea of the pernicious anemia? Halli Wali, leader will tell us. You two guys. Yes, leader, come on. Yes. Any idea of the pernicious anemia? No idea. At least there is an idea. Idea or no idea? Yes.
Intrinsic factors are produced by peripheral cells, and antibody is covering it, and there is no absorption of B12.
Excellent. Very good. Antibody neutralizes the intrinsic factors. When it neutralizes the intrinsic factor, so it leads to inability of the absorption of vitamin B12. Vitamin B12 not absorbed, lead to pernicious anemia. Pernicious anemia. Tamam. Okay, good. So in type 2 hypersensitivity we have IgG and IgM. Tamam. Now what we said? We said, just to quick summary, type 1 hypersensitivity, IgE is on the mast cell, antigen is coming from the outside. Type 2 hypersensitivity, IgG, IgM is wandering, antigen is present on the MHC, on the antigen presenting cells. They are already present on the antigen presenting cell. And then type 3 hypersensitivity reaction is, this is the unique type of the hypersensitivity reaction, where both antigen and antibody, they are in the form of complex. They are in the form of complex and they are moving, they are free. In first, antibody was fixed, antigen free. In second, antigen was fixed, antibody is free. In third, both are free. Both are free. Move here and there, here and there. Now you remember, you know that one of the function of the complement, there are 4 functions of the complement system. There are 4 functions of the complement system. What is the first one? Okay, what is the second one? What is the third one? Huh? And what is the fourth one? Very good, excellent. Immune clearance. This is the 4th function of the complement system. It has to remove this. It has to remove this. So what will happen? But if it is not removing this, antigen antibody complexes are too much, too many antibodies are there. This antigen can be from outside, can be from inside. Exogenous, maybe endogenous. So when there are too many antigen antibody complexes, they are moving in the blood. They are moving around in the blood. When they are moving around in the blood, so they are moving around and they go in the areas, many areas of the body, and they go and they start problem there. They are stuck up there. When they stuck up there, they start problem there. What type of the problem there? They start disease. Gentlemen, what type of the problem will be there? Either you are with us or you are with not with us. So either they will start localized inflammation, tamam, they will activate the neutrophils, there will be neutrophil degradation, process of inflammation start, they will start the activation of complement system. When they will start the activation of the complement system have two mechanisms. Either it will make MAC, you know MAC, membrane attack complex. When it will make MAC, it will damage the cell membrane, it will damage the endothelium lining. Or when they will make MAC, in between what they will make? They will make C3A, C5A, C5B, C3B. All these are also activating the process of inflammation, opsonization, process of inflammation. Together, this whole mechanism, it leads to a localized infection in the area. So there can be two types of the reaction in this. So we'll go to the type 3 hypersensitivity. It is an immune complex mediated, which is formed in the circulation by the deposit and deposited into the blood vessel and leading to the complement activation and then acute inflammation. The antigen may be from outside or may be from inside. You know what happened inside? From where the inside antigen is coming? Inside antigen is technically coming from the DNA. Sometimes the body DNA, the nucleoproteins, they become antigenic, and the body is sensing them as an antigenic. The body is sensing them as an antigen, although they have our own DNA. So this happens sometime. So inside antigen, and when this inside antigen is activated, so small amount of the antigen antibody complex may produce during normal immune complex. Normally it is produced, but it is removed from the complement. It is only when these complexes are produced in large amount, number one. Number two, they persist. Number three, they are deposited in the tissue. When they are in the large amount, they persist for the long time and they are deposited in the tissue, then they become pathogenic. So this is called pathogenic immune complexes, may be in the circulation. When in the circulation, they create systemic type of the infection, they create systemic type of the illnesses. When they go to the localized area, they cause localized infection. So two types of the problems will be there, systemic and localized, systemic and localized. When they are moving around, they create systemic infection, and when they are localized in particular area, so they create localized infection. Clear? So systemic and localized. So here, for example, see here, this is the basement membrane, this is the endothelium lining. Endothelium lining is which tissue of the body? Which tissue of the body is present in the endothelium lining? Okay. Which tissue of the body? Yes, what is your idea? Last man. Which tissue of the body has endothelium lining? What is your idea? Which tissue of the body has endothelium? Less, Osdami. Blood vessels. So blood vessels have endothelium lining. Your level question will come and I will ask you, don't worry. Blood vessels have the endothelium lining. When the endothelium lining, these are the antibodies. Tamam? Which part of the antibody is this? Come on. Which part of the antibody is this? Which portion of the antibody is this? Yes? Fab region. And this is called epitope. Epitope, tamam? And this is the FC region. Clear? So the endothelium lining fixes with the antibody with the this one antigen. So this antigen antibody complex, this is the immune complex. And what will happen when they are fixes here? They will start process of inflammation. This is neutrophil, and the neutrophil will secrete granules, and you can see the damage here. The damage is a start. The damage is a start. Later on, what will happen? There is one more slide, but it's anyway. So this leads to damage here, enzymatic release and damage of the cells. The type 3 hypersensitivity reaction is immune complex hypersensitivity. If it is generalized, we call it serum sickness, or maybe involve individual organs, so we call it localized infection, like SLE, Arthur's reaction. If it is involved in the kidney, it causes nephritis. If it involves the lungs, we call it aspergillosis. If it involves blood vessel, we call it polyarteritis nodosa or polyarteritis. If it involves the joints, we call it rheumatoid arthritis. This immune complexes love synovial membrane. It goes and enter into the synovial membrane and causes problem in the joints. So in order to summarize it, we say there are two types of the infection: generalized infection and localized infection. Generalized infection when it is moving in the blood, when it is moving everywhere. Localized infection when they are localized to particular area, So the reaction takes 3 to 10 hours of the exposure of the antigen. Arthus reaction, localized reaction, mediated by soluble immune complexes. Mainly the immune complex antigens are IgG, but sometimes IgM also comes here. The antigen may be exogenous or may come endogenous. The cell activation is the complement. Anaphylatoxin mediated activation of the mast cell and phagocytes. Complex mediated phagocytosis, release of the phagocytic granules and then cytokines into the circulatory area, the local environment, and then leads to damage. Now the sequence of the events, what happens? Here for example this is antibody, here is the antigen, tamam. This antigen antibody complex activate the complement system C3a, C5a, activate the neutrophils, neutrophil release, granules, degranulation will be there, and these chemicals are released, basophilic, neutrophil, histamine, all these are released. In addition to this, and all these things happen at the endothelium lining, endothelium lining of the perivascular area of the cervix, of the area where it is situated. In addition to this, what happened? The platelets, they come and attach to the endothelium lining, they come and get together, make a platelet clump together. So 3-4 events goes simultaneously: neutrophil basophil activation, complement activation, localized inflammation, and platelet activation, and the platelet come and plug together. When the complement comes and plug together, they make microthrombi, the thrombus formation, macro small thromboids are there. In addition to this, clotting factors are activated, and then some of the clotting factors, they come and attach on it, so they make a thrombus formation, a clot formation there. What will happen next? With the help of the C3A, C5a, the chemotactic mechanism, these are the chemotaxis, the more neutrophil will come, more basophil will come, the localized monocyte will be activated, and then this damage will be there. The endothelium line will damage, and then there will be a subendothelial accumulation of all these fluid material will be there. Clear? This will lead to vascular damage, vascular blockage and vascular damage. It can lead to vessel blockage and vascular damage because they are the perivascular area, small vessels area. When they lead to vasculitis and vascular damage, there can be two mechanisms: number one, vasculitis, inflammation of the vessels wall, and number two, vascular blockage. When there is a vascular blockage, the blood supply will be there more or low? The blood supply will be low. When the blood supply will be low, the oxygen will be more or low? Less. It will lead to ischemic damage as well, hypoxic and ischemic damage as well. The whole mechanism will lead to a damage in the particular area. That's called localized infection. This is called localized. If it is in the skin, localized necrosis. We saw in one of the example in type 2 hypersensitivity, localized Arthus reaction. If it in the joints, localized infection, localized inflammation. So these leads to a localized area of the damage. So here antigen, immune complex, C3a, C5a, complement chemotactic actors, basophil granules, vasoactive amines, platelet plugs, damage, and then endothelial damage. Clear? Two types of the diseases, systemic and localized. Systemic immune complexes are actually very unique type of the diseases. Particularly the patient, they are suffering from thrombocytopenia, autoimmune hemolytic anemias, or leukopenias, or the whole combination thrombocytopenias. These type of the people, they develop these generalized type of the infection, generalized type of the hypersensitivity reaction. This is called serum sickness, serum sickness. And it happens in the way, for example, patient, I am just giving you a story. If a patient is suffering from thrombocytes deficiency, autoimmune thrombocytopenia, tamam? Actually it happens with us, me with well, so I know this in a little bit more detail. Thrombocytopenia, not with me, one of my. So if a patient is suffering from thrombocytopenia, how the thrombocyte will decrease? Because the thrombocyte is coming from the bone marrow. Thrombocyte is coming from the bone marrow. And in the bone marrow, which cell will synthesize the thrombocytes? The myeloid cells. There are two types of the cell, stem cell, myeloid stem cell and lymphoid stem cell, isn't it? The myeloid stem cells are responsible for formation of the thrombocyte, red blood cells and WBCs, clear? So if there is a problem in the myeloid cells, so the thrombocyte will not be synthesized, even the rest of the other will not be synthesized, tamam? There can be autoimmune destruction of the thrombocyte by itself as well, but if it is coming from the myeloid cell, so there will be no thrombocytes. Now how the myeloid cell get damaged? Autoimmunity is made, antibodies are made against the myeloid cell, antibodies are made against the myeloid cell. So the issue is this, that what happened? Our own antibody system, T lymphocytes, our own T lymphocytes, they are dangerous and they kill the myeloid cells. Gentlemen, they kill the myeloid cell. When they kill the myeloid cell or they damage the myeloid cell, when they damage the myeloid cell, so thrombocyte will not be there, clear? This is the outcome. When the thrombocyte is not there, what will happen? Bleeding tendency will be there. Everywhere they will be bleeding, everywhere they will be bleeding, tamam? If it touch, they will be bleeding. From the nose, if there is too many thrombocytopenia, from the nose you will be bleeding. How you treat it? Now you recognize the problem is in the autoimmunity, the problem is in the autoimmunity. Unfortunately it happens with my mother, she was having thrombocytopenia. So we recognize it that there is something wrong in the myeloid cell and it is because of the autoimmunity. So what to do? You give immunosuppression. How you do immunosuppression? Corticosteroid is not working. You have to give, like what immunosuppressive? No. I mean, what is the mechanism? What you want to kill? Because this is T cell. This is T cell. This T cell is against your myeloid cell. This your own T cell. Your own T cell is against your myeloid cells. They damage your myeloid cells. When they damage your myeloid cell, WBC will be less, platelet will be less, RBC will be less. It will lead to a situation pancytopenia, isn't it? What is the idea? The idea is that you give platelets, you give WBC, you give RBC. For how long you will give this? Because this is continuously damaging it. This is continuously damaging. So the problem, the issue is that what to control? Control this one. Control T cell. If you control T cell, then if you control this one, this myeloid will not be damaged. When the myeloid will not damage, it will recover. When it will recover, the WBC will recover, the platelets will recover, and the hemoglobin will, the RBC will recover. Clear? This is a simple situation. So we give antibodies against this T cell. We give antibodies against T cell. They are called ATGs, anti-thymocyte globulin, ATGs. I was here, and when we contacted a doctor, and he said, okay, Prof will start ATGs. I said, okay, go ahead. We don't have any option. But he said, you know the success rate? What is the success rate? Just 30%.
Why?
30% success rate. Failure is too much. Failure is too much. Now what is the hypothesis of the failure? What happened in the body? Huh? No. You know what happened is a strange situation. Because it happens, so what happened in the body? This is T cell, is a muscular T cell. What we do, we take this T cell from the body, we put this T cell in the horse. We put T cell in the horse. Now this T cell is antigenic for the horse. Clear? And horse will make what? Antibody against this T cell. This is the human T cell. You understand my point? We put it in the horse and a horse will make antibodies against that. Then we take horse antibodies horse antibodies, horse serum, tamam, horse antibodies. This is called, it's called anti-thymocyte globulin, and we take that horse antibodies and inject it into the human, the patient who is suffering from this disease. Clear? As soon as you inject those horse antibodies against the T cell, they are against the T cell, isn't it? It's function smart, quick function, mashallah, and they start killing the T cell. They are damaging the T cell. When they damage the T cell, the myeloid cell recover. The myeloid cell recover. When the myeloid cell recover, hemoglobin back normal, WBC back to normal, platelets back to normal, and you are happy. You say, wallah, everything is fantastic.
There is no immune difference.
Sorry?
No immune difference.
What is it? No immune difference?
No immune, there is no, there is an inflammation and disease.
No, for early days nothing happens. That's why I am saying. This is antibodies. This antibody is against the T cell. Tamam? The T cell is present in your body. We put antibodies from outside against the T cell. They will come and they will see which T cell. This T cell attack with this T cell. When they attack the T cell, myeloid cell will recover. Yes? Yeah, this is the mechanism. But what happened after the 10 days? 10 to 11 days. Your own B cell, they become activated. What is this? Then your own B cell will sense this antigen, which is you got it from the horse. For them, this is an antigen. You got my point?
Antibody is an new antigen.
Yeah, the antibody, they will say, oh, what is this? Who is this? Ya Allah, hada khariji, mushkila. Huh? Coming from Pakistan, mushkila. Huh? So this antibody will sense this antibody which is coming from the horse as an antigen, and they will make B cell, T helper cell will be activated, B cell will be activated, plasma cell will synthesize, and then plasma cell will make too many antibodies against this antibody which is now antigen. Clear? So there will be an antigen antibody complex. The T cell will happy now again, because there is nobody to kill the T cell. The T cell is happy and the T cell will kill again the myeloid cell. Clear? Now this person is trapped in two situations. This person is trapped in two situations. The situation number one, the T cell is happy again, he will damage the myeloid cell, the myeloid cell will decrease the thrombocyte, will decrease the RBC red blood cell, will decrease the WBCs. Tamam? So this is the previous situation, situation number one, it will come again. On the other hand, this gentleman will have a problem of too many antigen and too many antibodies complex. And these antigen and antibody complex, they will be remain there and they will move around in the body. They will move around in the body and they will start systemic infection. They will go to the brain, damage the brain system, hypothalamus, temperature will rise, goes to the joints, inflammation will be there. Everywhere, this type of the situation goes to the heart, pericardial infection, goes to the pleura, pleural infection, everywhere, goes to the kidneys, nephritis, tamam? Everywhere, this situation, the systemic involvement is called serum, because now the problem is in the plasma, this is called serum sickness. So after 10 to 15 days, the patient develops serum sickness. Clear? And that is a serious situation. So this happens, so this situation, this is systemic, is this clear now? I am just repeating again. What happened, what is the serum sickness? Serum sickness is a systemic infection, this is a localized infection. Local immune response, I am going to directly here. Serum sickness, fever, rash, joint pain, lymphadenopathy, glomerulonephritis, time course days to week after the introduction of the foreign antigen. Foreign antigen mana? The antibodies which introduced for the T cell cause allogenic serum, drugs, infection, autoimmune disorders. So what will happen? This is generalized infection will occur. Generalized infection. Everywhere in the body. Everywhere in the body. This is localized infection, systemic lupus erythematosus. So,
Isn't this the one with the kidney?
sorry,
This one.
this one?
No, we're going after. Lupus nephritis.
Lupus erythematosus, SLE. We discussed this in the type 2 hypersensitivity even. It is one of the example of the type 2 even, tamam. But when it is generalized, this type of the delayed hypersensitivity, we call it SLE is one type of the type 3 hypersensitivity even. No. So this type of the infection. So what is the actual situation? The actual situation is there is T lymphocyte of the body, your own T lymphocytes, they are against your myeloid cell. Myeloid cell will decrease the production of these WBCs, RBCs, platelets. You give antibody against this T lymphocyte. The T lymphocyte antibodies will come and kill the T lymphocytes, and then your blood cell will recover. But after 10 days, your B cell, your own B cell will recognize this antibody which is coming from the outside as an antigen, and they make antigen antibody complex with this, and then start damaging everywhere in the body. This type of the infection is called serum sickness, serum sickness. Localized infection are the localized immune complex. When it damages to the local area, it is called Arthus reaction, and it is related to the particular area, because the particular area the blood vessel will be damaged, vasculitis will be there, necrosis will be there, and it lead to a deposition of the immune complexes in the dermal blood vessels, or activation of the complement, or recruitment of the polymorphs, and resulting inflammatory response. If it is in the vessels, it leads to vasculitis. If it is in the kidneys, it will cause nephritis. If it is in the joints, cause arthritis. If subcutaneous, Arthus reaction. If inhaled, farmer lungs. All these are the type 3 types of the hypersensitivity reactions. Localized Arthus reaction requires 3 to 6 hours after the exposure, and massive influx of the neutrophil, edema, and necrosis. So this is the antigen coming from the outside, antibody complex, polymorphs, then platelets sequestration, local area damage. This is the Arthus reaction, this is the wheel and flare reactions, and serum sickness we discuss. So in summary, we say type 3 hypersensitivity reaction, it is the interaction of immunoglobulin G and M with the antigen. The antigen may be exogenous or endogenous. Immediate size immune complexes, intermediate size immune complexes, small size immune complexes, they are clear, but 3 factors are there. Maybe large size, too much, persistent increase, then it creates problem. Small size of the antigen antibody complexes are synthesized, but they are clear. But if there are too many, large size and for persistent time, long time, then it creates problem. Complement protein bind to the immune complex as a part of normal physiological process. During hypersensitivity type 3 reaction, sustained complement immune complexes, sustained complement immune complex interaction lead to production and activation of the complement component responsible for the recruitment and phagocytosis. Recruitment is chemotaxis. Cell mediated tissue damage occur as a part of type 3 hypersensitivity, and then involving activated basophil, peripheral circulation, and then neutrophil arrange with the endothelium lining, and then vascular tissues. Type 3 hypersensitivity can manifest as an acute or chronic diseases. Self and foreign antigen can provoke type 3 hypersensitivity reaction. Self antigen can be nucleoprotein. Some non-specific immune complexes can also cause type 3 hypersensitivity reaction. Clear, guys? So this is type 3 hypersensitivity reaction. Now type 1, antigen antibody, tamam, antigen free antibody. Type 2, antigen fixed antibody free. Type 3, both are free. Type 4, both are fixed. No antibody. Clear? Type 4, no antibody. So then what? Only antigen, and what next?
Cell mediated.
T cell, cell mediated. Tamam, very good, excellent. So type 4 hypersensitivity reaction. Is this clear, guys? Is this clear, the difference? Type 1, antigen antibody. Type 2, antigen antibody. Type 3 antigen antibody complex. Type 4 MAFI antibody, antigen and T cell. Clear? So type 4 reaction depends on the interaction of antigen with the T lymphocyte and has been called delayed type of the hypersensitivity reaction. Phi antibody मौजूद? Huh? Type 4? No. The delayed type of the hypersensitivity reaction involves cellular activation of the T helper cells, and then T helper cell, when C helper cell is activated, what happens? Cytotoxic T cell is activated, and then so on. Subsequent cytokine secretion gives rise some pathologies. In many cases, sustained release of the antigen and continued activation of the T cell result in amplification of the response and provoke excessive immune activation. Continuous antigen, continuous immune response, T lymphocytes. Tamam? Is this clear? Continuous antigen, continuous immune response. When there is and for a long time, sustained for a long time, immune response will be very serious, clear? Normal immune response, for example, there is just swelling and redness. But if there is a continuous inflammation, so what will happen? This area will be maybe hard, maybe tough, maybe red, more hard, more tough. Clear? So this is sustained infection. And these events, basis of the development of broad range of inflammatory pathologies, include erythema. What is erythema? Erythema? Redness, edema, swelling, and granuloma formation. Hard and swollen, and extended development of Baden fibrosis or necrosis. Tamam? Exit 15. So type 4 hypersensitivity, classical example of the is tuberculin test. We discussed this in TB. Manto test, where we inject purified derivatives of purified purine derivatives, all tuberculin, and then it is characterized by induration and erythema. The delayed reaction are 12 to 24 hours. Particularly in this, we check after 72 hours or 74 hours, and characterized by induration, hardness, and erythema, redness. So tuberculin is the most common example. What do you do here? You just inject intradermally tuberculin, mark here, and after 72 hours you see it. If there is a delayed type of the hypersensitivity reaction, you will be swelling and redness, and you measure it. If it is more than the recognized one, you say, oh, this is tuberculin test is positive, delayed type of the hypersensitivity reaction is positive. So what will happen here? T lymphocytes. The issue here is that, what is the issue? The issue is of T lymphocyte. Which T lymphocyte it will activate?
No, T helper will be activated.
T helper will be activated. Very good. Baden cytotoxic Baden. T helper will be activated. Now, you know T helper cell. What is the types of the T helper cell? Yes, my friend will tell me. Come on. Bassam, two Bassam together. Huh? You are not Bassam, huh? Yes. T helper cell. T cell malum. Helper cell malum. So yes, types of the T helper cell. TH1. So first what happened? There is the TH. What is that? T0. TH0. Naive T cells. TH0. Naive mana innocent, huh? Not immature, but innocent type. Naive. Naive mana that, naive, what is naive? What is the classical example of naive? Naive mana ignorant. You understand upon? When is your exam? I don't know. What is your exam? I don't know. Which block is this? I don't know. Who is the block planner? I don't know. Which year you are? I don't know. This gentleman is called naive. This gentleman is called, what is it called? Naive gentleman. I am just giving you an example. So this naive T helper, it has two types, T helper 1 and T helper, they have different characteristics, they have different characteristics. The T helper 1 cell here, this one have two, interleukin 1 is present in all of them, interleukin 1 is present in all of them. But here in this T helper 1, they have two extra things. One is tumor necrotic factor alpha, TNF alpha, another is gamma interferon, gamma interferon. So this is TH1. So T helper cell, antigen comes, attached to the phagocytes, activated T helper cells, TX helper convert into T helper 1, and then the process of the inflammation starts. So here antigen presenting cells, actually you know what happened, particularly the example, if we see the example of the tuberculosis, Mycobacterium tuberculi, it enters into the lungs, and in the lungs it goes to the alveoli. When it goes to the alveoli, the alveolar phagocyte try to kill it, but this Mycobacterium tuberculi, the tuberculum bacteria is very strong bacteria, it is very strong bacteria. The phagocyte don't have the capacity to kill it completely. So what they do, they brought a piece on the surface. When they brought a piece on the surface, with which protein they brought a piece on the surface? MHC. So here they brought a piece here, and then they attach with the CD4 cells, with the CD4 and T helper cells, with the TCR receptor. So they come to the attach here, and then this CD4 T helper cell will convert into TH1, and when it converts into TH1, then start the process of, so antigen presenting cell, macrophage Langerhans cells, and then detaching mediating T helper cells, and generally CD4 and CD8. CD8 is cytotoxic T cells. Then what will happen? These MHC, activation of this will activate it, will convert this macrophage as an activated macrophage, and then the process of tumor necrotic factors, oxygen free radicals, and then nitric oxide, all these effects will be there, activation of the process will be there. They will try to kill it. In this killing effect, they transformed into a type of the cells by this process. When they are activated, when they have tumor necrotic factors and all those things, they transform into a cell that is called epithelioid cells. Epithelioid cells, epithelioid cells, they are mononucleoside, the macrophages at the site, they are called epithelioid cells. So this epithelioid cell having this bacteria inside, surrounded by too many T helper cells. And remember I gave you the example that this is the thief, and the thief is living in the, he married the daughter of a police head and he is living in his home. Who will catch him? Who is going to catch him? Nobody is going to catch him until unless the Baba die, the father-in-law died, then somebody will come catch him. So this thief is inside in the macrophage, which is now a transformed cell, which is an epithelioid cell surrounded by these many T helper cells. This is called, this make a complex, this make a complex, it's called granulomere-Gohan complex. Tamam? So this may, and this where it happens, there is a localized infection in the alveoli, and then from here it goes to the lymph node, this goes to the lymph node, and then there will be a lymphadenopathy. So this is called localized infection and lymphoid infection, lymphadenopathy, lymphs are involved. So T helper, they are activated rather, this they are not activated here in the delayed type of the hypersensitivity reaction. T helper 2, yes, in T helper 2, this T helper 1 activate the delayed type of the hypersensitivity. T helper 2 acts on the B lymphocytes, immediate reactions. Tamam? So here this type 4 hypersensitivity involved in the pathogenesis of autoimmune infections, tuberculosis, leprosy, and these are the type of the infection where antigen is continuous, sustained, and for a long time, Another type of the delayed hypersensitivity is contact dermatitis, and with the poison, some type of the plant poison. So how you diagnose it? We diagnose it by the cutaneous Mantoux test, or by patch contact dermatitis, or in vitro we see the mitogenic response of interleukin 2 production. Corticosteroids, immunosuppressive therapy, they can be used. In tuberculosis, if you remember, we discussed in one of the practical, in one of the PBL, in tuberculosis you give, for how long you give treatment?
Rifampicin and isoniazid.
For how long? 6 months, 9 months, to the maximum 12 months. Why we give this long antibiotic? Yes.
Because there is a latent phase.
This is a latent phase, but this is the situation.
But it could later break through and get.
This is the situation. You cannot reach here easily. You have to give continuous antibiotics. So sometime when the Baba is, father-in-law is outside, moving barra, maafi mawjood, then some antibiotic will go there and kill it. Tamam? So that's why we give it for a long duration of time. So in order to disinfect and in order to kill the microorganism. Clear? Okay guys, so this is the tuberculin test. We give injection intradermally, see it after 72 hours, and then we measure it. How much is the redness and swelling? So there is a criteria for that you can see, and then you say, oh, the tuberculin test is positive. Tuberculin test is positive. This is dermatitis versus tuberculin test. Poisons, some poisons are there, and again the poison, they behave like heptane. You know what are heptane? Heptane is like you have a younger brother, tamam? Your younger brother is a nice gentleman. You have elder brother. He's a nice gentleman. He is a nice gentleman. And you know that your younger brother is good, going to masjid, reading, everything. But after a few times you recognize that he has a friend from outside. He is a friend, new friend. And once you recognize who is this, he said, he is my friend, he is my new friend. And after a few days you notice something strange things in your brother. Tamam? Awal maafi smoking, now smoking. So what will be your idea? What you will say? Who make this your brother bad? You will say, oh, this friend, the company of the friend, isn't it? This is the example. Our body has normal antigens. The antigen are normal, functioning properly, everything is normal. Blood group antigen, they are functioning normally. Body system don't recognize them. But we take some medicine, for example, or from some outer things come from the outer side, and they attach to the present antigen. When they attach to the present antigen which is present inside, they turn that normal antigen, which is a good boy, into a bad boy. Clear? That friend, in simple language we call it a friend from other side. Here we call it heptane molecule. Here we call it heptane molecule. So it's happened sometime in the body when these heptane molecules comes, sensitize the T helper cells and then antigen presenting cells, and then the whole process of the inflammation gets starts. So here you can see some sort of a allergic reactions here, contact dermatitis, sometime very serious contact dermatitis. This is the granuloma formation. What are the characteristics for the granuloma formation? Antigen should be continuous, persistent for a long time. Tamam? So when continuously antigen is coming, continually your immune response is there, continually there is an inflammation. So what will happen? There will be redness, swelling, and hard bodies will be there. This is called granuloma, granulomatous infection. Clear? Commonly in leprosy or all. So, in summary, we say type 4 hypersensitivity is also called delayed type of the hypersensitivity reaction. It represents immune reactivity where T lymphocytes have encounter with the antigen. It is termed as delayed type because start with the 12 to 24 and 74 hours after the exposure of the antigen. Delayed type of the hypersensitivity can manifest with the contact with allergen or infection agent, giving rise to localized inflammation, localized infections, or generalized infection, serum sickness. The classical manifestation of the delayed type hypersensitivity is cutaneous, contact dermatitis, tuberculin, granulomatous hypersensitivity, and then broader classification now includes subdivision of the serum sickness and the localized infection. DTH involves a protective host mechanism which combat with the pathogens. However, excessive DTH response can lead to, come here, yes, any mushkila? No mushkila? Can lead to immunopathologies exhibited by granuloma formation. Granuloma, this is granuloma. Granuloma. For granuloma, what is this? How excessive evolved protective host mechanism compare, however excessive or even response, excessive response, continuous infection, continuous response, continuous antigen, continuous response for a long duration, it lead to granuloma formation, fibrosis, and then finally necrosis. DTH reaction are prominent in autoimmune diseases and may also be demonstrated to play a role in the response of transplant tissue rejections, allogenic rejections. So, contact dermatitis 48 to 72 hours, eczema, T cells and macrophages. Tuberculin 48 to 72 hours, local induration, lymphocyte and monocytes. A granuloma formation 28 to 28 days, long duration, hardening of the tissue area, monocytes, giant cells, epithelioid cells, fibroblasts, and persistent antigen stimulus, chronic infection, persistent antigen infection, chronic infection. So, last but not the least, last session of the host defense, type 1, antibody IgE, type 2 IgG IgM, type 3 IgG IgM, type 4 none. Antigen exogenous, maybe cell surface, this is free, this is fixed. Soluble, antigen antibody soluble, and this is intracellular. Response time 15 to 30 minutes, minutes to hours, 3 to 8 hours, and then 48 to 72 hours. Appearance, wheal and flare, lysis and necrosis, erythema and edema, localized edema, and erythema and induration, long granuloma formation. Histologically, basophil eosinophils, antibody and complement systems, polymorphs, complement system, monocyte, lymphocyte and T cells. Transfer with antibody, 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 and this is with T cells. Example, hay fever, asthma, flu, type 2, pemphigus vulgaris, Goodpasture syndrome, erythroblastosis fetalis, ABO incompatibility, all these are the examples. Tamam? Farmer lungs, SLE, and type 4, TB, leprosy, granulomatous formation, granuloma formation. Clear? Thank you very much.